They're right here. Where else would you like them? I'll put them anywhere you want in this room if it helps you to find them. Otherwise, I'll just lay them right there. Okay, I got 3 left. Highest bidder. Shannon, do you have a handout? Okay. Okay. So I understand there's questions. Dr. McNeil said you have questions about presenters writing questions over drugs and my stuff over drugs. So he asked me to look at them. I will. I'll look at the questions. If there's anything in conflict, I'll raise it with him. So my focus mostly in assessing you is going to be on the pharmacokinetics of these drugs. That's the real important part, I think, to understand from a practitioner. So I'm not going to say it's a focal seizure, which drug are you going to use? I'm not going to do that. I'm not going to go over how, given a diagnosis, you use these drugs. I'm going to talk more of the problems and the things that you need to know when you are coming across somebody who is on these drugs. Particularly if you add a drug to these regimens or you take something away, it will have major effects. It could have major effects on the serum concentrations. And serum concentrations for a lot of these drugs will correlate to clinical efficacy. So my focus is going to be kinetics, and it's going to be the side effects. Some of it will be with dosing, because some of them have unusual dosing approaches. I'll also talk a lot about pregnancy and contraceptive use. Okay, and that's the majority. Does that help? Yes. Okay. All right. Let's get started then. These drugs are fascinating from a kinetic standpoint. Most of them act on the liver, or a lot of them have liver effects, and that's why they cause so much trouble. The newer agents that you'll see, so that's the older products. They're very effective, but they're kinetically complex, and they have lots, and their side effects are significant. Almost all of these drugs are going to have neurologic side effects. Almost all of them have the same general type of side effects. They're neurologic. And those usually occur early on. Then each of them have their own kind of systemic effects. And some of them can be quite serious. And so it's really important to know those. So as we go through, that's my emphasis. The newer agents are getting around that. So that's what you'll always find, is that when you have a class that comes out of drugs and it's been around for a long time, the problems that occur, that's usually what drug manufacturers will look to try to circumvent or overcome. So when you have the ability to monitor serum levels, that's great, because you can correlate clinical effect with what's in the blood. There's a great advantage to that. But then the disadvantage is that you got to do it. You got to monitor it. So a lot of the newer agents don't have that. They don't have a correlation between a serum concentration. It's like Lamotrigine. We don't monitor serum concentrations of that. But for valproic acid, phenytoin, phenobarbital, the older ones, carbamazepine, we do. So the newer agents try to address renal excretion, not metabolized by the liver, don't interfere kinetically with other drugs, and they don't have usually the big side effects that you see with the others. So that's just kind of an overview. So in terms of goals of therapy, on the top of page 3, we want to eliminate their seizures. In some instances, this is easy to do. In some, it's not. Some you cannot. So good control may not mean seizure-free. So you can have good seizure control, but you still have seizures. So it may be taking the number of seizures down to a smaller number. So what did you talk about, or did you all talk about when to start? medication. Do we start, everybody has a seizure, do we start medication on? No. Why is that? Right. If there's a provoked reason and that is resolved or goes away, then usually you don't have to treat them. So usually you have, it depends on what caused the seizure, type of seizure, risk of recurrence. That is what's going to be, will drive whether or not you start a drug. So if you look under their risk of recurrence, 40 to 50%, so it's pretty high. People who are at most risk would be some type of insult, so brain injury, EEG abnormalities, brain imaging abnormalities, having seizures at night. So those are people are more at risk for having a recurrence. So those are the folks that we're probably going to treat. So in general, starting anti-seizure drug therapy after 2 or more unprovoked seizures is usually a good reason to start. But now sometimes we start when there hasn't even been a seizure. Like if you're doing neurosurgery and you're going to evacuate a subdural hematoma. You may start before because we know the risk of seizures is so high that we're going to prophylax them through that period. And then within 6 to 12 months, we're going to try to titrate them off of that. So it really is variable as to when you start medicine and when you don't. You know, it's really problematic. When you start, you make major impacts on their life because what's one of the first things that will happen to them in terms of just lifestyle? They'll usually, states will, each state is different, but most states are going to have something that says something about the inability to drive when you start seizure medication, and they may require differing lengths of times that you have been seizure-free before you can legally drive. Okay. For women in childbearing years, it's pregnancy. So did you all talk about the effects of, okay, so several things. A lot of the drugs that we use are very teratogenic, so we want to prevent that. So it's really important to have planned pregnancies. The other is that if you have a seizure when you are pregnant, you have a high risk of that pregnancy ending. So there's lots of impacts that once you commit somebody to a therapy that needs to be taken under consideration, so it shouldn't be done lightly. Okay. Choosing a drug. One is it will depend on what is the type of seizure. So having a good diagnosis is going to be important. I would just imagine most of you, unless you're in neurology, that is not going to be your job. You're going to refer that out and get that diagnosed and worked up before a drug is started. And I would say most likely you're not going to start these drugs unless you're in that kind of practice. If you look over on page 5, I've given you the different anticonvulsants for a specific seizure type. I'm not really going to approach my assessment from that standpoint, because a lot of times people have mixed seizure profiles, and it's not the way I'm going to teach it. So anyway, it's there for you to refer to. So seizure type, the other potential adverse effects really need to be considered. So they all will have neurologic symptoms. Okay? So some of the things that would influence your decision is some of the drugs are referred to as adjuncts. So what would be adjunctive therapy?
Adding it to something that's already on.
So often adjunct therapy is not usually used as first line or monotherapy, even though you'll see that through there. So sometimes drugs that are adjuncts are always going to be added to another anticonvulsant. Anytime you're using 2 anticonvulsants, your side effect profile really goes up. The other is that they will influence each other. So the liver metabolism of the older agent may impact the new one, Or the new agent you're adding, like if you add lamotrigine to valproic acid, you may have problems because it will influence valproic acid, and valproic acid will affect its metabolism. Systemic toxicity, a lot of it will be around liver, bone marrow, endocrine effects are pretty common, and we'll go through the big ones in with each of the drugs. Most of the drugs have a potential to worsen psychiatric illnesses. So if they have anxiety, depression would be probably the biggest thing. Those drugs can also impact their depression symptomatology and also their treatment. The other one is that most of them have are associated with an increased risk of suicidal ideation or action. So keeping that in mind. The other is potential drug interactions. Anytime you see an anticonvulsant, you have to think drug interactions are going to occur. They just are. They are so active on the P450 system. They induce, they inhibit, they auto-induce. Very interesting, but a nightmare. You have got to, anytime you add a drug to an anticonvulsive therapy, you've got to think, what am I doing? What will be the outcome? Or if you see that anticonvulsant therapy is added to something you're doing with the patient, you need to be looking at where the problems can occur. The older agents usually are the more the problem. Phenytoin, carbamazepine, phenobarbital, those are really common. Drugs that will be commonly effective would be warfarin, the oral contraceptives, so the estrogen-progestin combinations. And we'll talk quite a bit about that. Okay, so those are just things to consider if you are changing a therapy or changing a regimen that contains an anticonvulsant. Other characteristics, age. Young kids usually can metabolize these drugs faster, so they may be on higher per weight doses than you would see with an adult. Kids usually are going to be dosed on a milligram per kilo basis. Adults, you may see that, but usually it's more of a recommended range of dosing. Older people, slower metabolism, higher risk of side effects. Renal is going to come in and be a problem for these folks with the newer agents. Women of childbearing years, so those on contraceptive, those who are pregnant or want to become pregnant. So induction of those hepatic enzymes are going to affect the estrogen-progestin combination. It will increase their metabolic clearance, so they'll become ineffective. This goes for the pill, the patch, the ring. I know we haven't had those yet, talked about them, but products that contain them. So there's lots of different forms that they can come in. The other thing to keep in mind would be emergency contraceptives, so the morning after pill. And they can buy those over the counter. They don't have to get a prescription from you. Those will also be affected, so we'll talk about an increase in dose. So these would be conversations to have with your women who are patients who are in their childbearing years. I can tell you from my experience in diabetes, it is really important to have, I start these conversations if I'm seeing patients as young as early teens. I start telling them things that they need to think about in terms of reproductive health and planning a pregnancy when they're early age, 13, 14. The one thing I've also learned is that a good relationship will go a long way. If women want to have a pregnancy and they know that you are likely to tell them they shouldn't or can't, like you can stop them, they will not tell you. So having good conversations, being very open, so that they will tell you I want to get pregnant. I understand the risk, but I want to get pregnant. That you need to have that relationship so they'll tell you. And always talking to them about plan the pregnancy, plan a pregnancy. Diabetes, we're going to talk about that a lot. Here it's the same thing, planning a pregnancy. Some of the drugs are very teratogenic. Valproic acid's awful. Carbamazepine can cause, so you have to tell them that. We want you to have a great pregnancy and the best baby you can produce. Okay? But so that means we don't want the drugs to affect. So it's really important to have that open conversation. Telling them they can't get pregnant, don't ever use those words because they'll not tell you anything then. Pregnancy, we're going to go through this again at the end. It's the folic acid. So because you've got neural tube defects that can be influenced by folic acid concentrations, and these drugs, valproic acid and carbamazepine, probably the two worst. All women, all of you, except Paul, Brian, you should be taking folic acid every day, at least 400 micrograms a day, or 400 to 800 a day, all of you, until you can no longer get pregnant. Because the neural tube defects that occur very early, like in the second week of gestation. So most of the time we don't even know we're pregnant by then. So it's important for you to do that. That's an overall recommendation. For women who are on something like carbamazepine, then we up the dose, and we'll talk about that again. So we do greater doses before conception and then at least through the first 3 months in order to decrease neural tube defects. Okay. You know what the neural tube is? You had? Okay. Have y'all talked about it?
We talked about spina bifida.
Talked about spina bifida. So you know that neural tube, when's it form? It's about 10 days to 2 weeks. So you have those 3 germ layers. What are the 3 germ layers? Ectoderm, mesoderm, endoderm. What's ectoderm produce mostly? Germ layer gives rise to skin, central nervous system. Mesoderm?
Yeah.
Everything in the middle. Mostly the vasculature part. What about endoderm? I'm just talking in general. That's gut. Okay. So early on, you just got flat organism. But eventually, that ectoderm starts migrating. And it migrates to the center, and then it invaginates. That's your early notochord, and eventually it will completely close over. Okay? That becomes then your neural tube, becomes your central nervous system. So these drugs, folic acid is really important in this process. It will prevent that closure, and so that's where you get those spina bifida or anencephaly in the neural tube effects. See, morphogenesis, it pays off. Dr. Hinke, who I took that from, would be very proud that I even remember that. Okay. Let's see. Just a couple of things. I think I picked this up again at the end under pregnant women. So during pregnancy, the best drug that controls the seizures is what is recommended. It's not recommended you switch during pregnancy in terms of losing control, seizure control. Other medical conditions, pay attention to liver and kidney. For the most part, kidney is the more problematic. Drugs that are totally eliminated by the kidney, then we'll have to have dosage changes, and I'll point those out as we go. Okay, so maximize. So any questions about those, or just a few things to kind of get your mind focused on, and then we'll keep bringing them up as we go through. Other medical conditions, also did those. Okay, successful outcome. Titration and monitoring. Most of the time, we start with a low dose, because the CNS side effects are early and they are really troublesome. Like, I can't stay awake, sedation, ataxia, they get dizzy or they can't walk right, or they get blurred vision. So those are really common ones early on. Most patients can be controlled on one drug, 80%. That's good, because the side effect potential goes, or the side effect and the kinetic interference goes down. And then about 10% will need 2 drugs. Start low, go slow. Monitor treatment regularly. So it depends on whose responsibility is this. Does the neurologist see them and hand them off to you for the most part, and sees them every 6 to 12 months? So that will be, may fall into your realm. Ask about adherence. Assess adherence at every visit. It's estimated 60% of patients who take neuroleptics are not compliant, not adhering. Okay, so always ask. Assess, why aren't you taking them? So assess barriers. Is it money? Financial? Most of it here is that they don't want to be on it. Okay? Or it's giving them side effects that they don't want to deal with, or are finding hard to tolerate. So always ask about that. Check drug concentrations. We'll go through which ones to do, because the drug concentrations can tell you, number one, if you're in a range that is likely to produce the outcome you want, which is no seizures. The other is if they're having side effects, their peaks may be too high. So peaks are usually associated with increased side effect potential. If they're staying under therapeutic for long periods of time, that may be leading to increased seizure frequency as well. Okay. Questions about those? Okay, top of page 5 then. This is still going on with drug levels. Drug levels also, anytime you change dosage formulations, you would need to reassess what the drug level is. Here, there are lots of formulations out there. You will find immediate release, you'll find syrups, you'll have extended release products, you'll have products that are designed to be released in parts of the gut. They are not interchangeable. So when you go from immediate release to an extended release, you may have to change the dosage amount. Okay. Or there's sprinkles for kids. What do you do with those as they grow and change? So anytime you change a dosage form, you need to remonitor the levels, because they're very likely to change. If patients are having breakthrough seizures, why is that? It could be the dosing range, or the dosing interval is too long, or they're just not staying in therapeutic range long enough. Anytime you add an interacting medication or you take it away, you got to relook at the levels. I can't tell you how many times in the hospital I get a call from a doctor going, I don't know, what are we supposed to do with this person? They say they're taking the drug, but they're seizing. I'm like, okay, check a level. Comes back. I said, I think they're probably not taking them. No, they say they're taking them. Level comes back 0. They're not taking it. So that's one of the ways to help you with adherence, and to start the conversation as to why aren't you taking your medicine. We talked about adherence. I pointed out that classification. That's for your reference. I'm not going to approach it that way. Okay. Any questions or comments? Anything I've said that contradicts what you've heard to this point? Okay. So let's start with the different products. What I have done is I have grouped them according to mechanism. Too bad Dim's not here, because this would drive her nuts. Most of these drugs, we do not understand how they work. They usually are changing some way the propagation of a action potential. Okay? So that may be it's on a sodium gate, it may be calcium, it may be that it's changing neurotransmission of like GABA or glutamate. So we may know general things, but specifically why it works, or why it works in particular people or particular seizure, we don't know. So I have grouped them accordingly. I'm not going to hammer the mechanisms of actions, is because they are just not well defined. Yes?
So how do they
they find that these work with seizures then if they don't know the mechanism?
Well, they can know some things, but in terms of the full molecular, like when you do that sodium channel, you know, what are all the ramifications that fall out of it? So sometimes these come about because, you know, they will screen a drug for multiple things. So when a drug is being developed, they'll usually have a target. We want to develop a drug that does this. But when you are testing it, particularly in animals, you start finding out when we do that, this goes away, or this is modified. So a lot of that comes out because of that. So they know they're affecting certain parts of the brain, but they may not understand all the molecular interactions that lead to then the fact that you have less seizure.
So in animal studies, they kind of figure it out.
Yes, but it also happens in people. Like I told you with essential tremors, they found out primidone, you give them to people with seizures, and lo and behold, their tremor frequency goes down. That happens a lot. When we get to diabetes and we talk about the GLP-1 agonists, we give them, and lo and behold, people lost weight, and they lost a lot of weight. Okay, so then the company starts going back and looking at that. Can we make hay out of this? Can we then market it? Well, Victoza did. They went after a whole new indication with that information. So a lot of times we figure out what drugs will do once they get into general use. Not uncommon at all. Okay, so valproic acid, we'll start there. Very common drug. Depakine, Depakote, those are two brand names to know. You'll see under the products, they come under valproic acid, rapid absorption, peak concentrations, 1 to 3 hours. Not necessarily important that you remember that. What I want to show you is how the different products will differ. So there's a syrup, so it'll be quick release. Then you get to Depakote. Most people are on Depakote because they get more consistent drug levels and the peaks don't tend to cause as much trouble with side effects. Here, look at the Tmax, 3 to 8 hours. So the peak is extended and it's not this rapid influx of drug and then off. That's when people get side effects. That's why people usually move away from Depakine. The extended release, Tmax 7 to 14 hours. So you can use that to your advantage if people are having side effects when they're at max dose, or I'm sorry, serum concentrations at max. See how you can use that? It's also a way for you to figure out the patient's complaining, look at the dosage form, look at the serum concentrations. They may be just staying too high too long. This is an interesting drug in that it binds to albumin, but the binding is saturable. Now we don't see that with most drugs. Albumin has a huge number of sites, big capacity to bind drugs. This one binds at a site that can become saturable. So once you saturate it, what happens to the free concentration? It starts going up. Okay? You hit about 80% max, and then the free concentration of the drug starts to increase. So what do you know about the free concentration of drug? It's the active moiety. So let's say you have somebody really stable on whatever valproic acid formulation. You add a drug and all of a sudden they start having more symptoms. Well, look at the protein binding. If you have a drug that is competing for that protein binding sites, it's knocking more free drug off. Free drug is free. It can go and do things. So that is one of the things to keep in mind with valproic acid. Saturable binding sites, highly protein bound. Anything that's highly protein bound can be greatly disturbed by putting on another drug that's highly protein bound that competes for that site. So the takeaway is remembering that factoid, and then if something changes, look at the drug that's been added or taken away. Okay. If they have low albumin, so your elderly, your renal patients, your poor nutrition patients may have low amounts of albumin. If that's the case, they can't bind as much. More free drug. It inhibits hepatic metabolism. So any drug that is metabolized by the P450 system is likely to be affected by valproic acid. It can cross the placenta, and the kid gets higher levels than the mom. So this is a drug that can cause a lot of congenital defects. So this one, you should star. All the ones that have therapeutic drug monitoring, you should star and note. Mostly it's going to be the older agents. This is an old agent. Therapeutic serum concentrations 50 to 100 milligrams per liter. Aha! So if you're switching from Depakote to Depakote ER, you need to increase the dose. Mark that. Something to remember. If you don't see these drugs very often, then what I would do is store in my brain the big things. Protein binding, liver. Do I need to worry about kidney? Do I need to worry about changing formulation? Or if I'm switching formulations, do I need to adjust the dose? I would keep those big concepts in my brain if you're dealing or seeing these come across. Or you're in urgent care, the person comes in and goes, I can't walk, I feel like I'm in a funny house, I can't walk straight, I got stopped and they thought I was drinking alcohol. And you're going, okay, you're on this drug. What have you added recently? What have you done? What's different? That should start cluing you into that it could be a drug-induced problem. I look at the world through drug-induced eyes. So I know that you don't, but I always do. So I always think, could it be a drug? Because that's my job. It's part of your job. Pregnancy, major malformations, avoid, 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 avoid. You ever watched the old Lost in Space? It's so far ahead of where you were. I mean, these were the 60s. So Lost in Space, ever see? Or the movie came out, I don't know, 20 years ago, probably before y'all were born. But they had this robot. You remember the robot? He's big, he's so retro looking. But anytime the family ends up going into space inadvertently, and they go to all these planets that are, just fraught with danger, and so they nearly lose their life every episode. But the robot, anytime they were in danger, he would flail his arms going, danger, danger! And he had this red halo that was around him. So that's what you need to think about. Google up the robot on Lost in Space, and then you'll link that to valproic acid, and you'll work it out. Okay. So other adverse effects. GI, common. Most of the drugs are usually well tolerated. This one is not so much. Nausea, vomiting. So taking it with food or after a meal, switching to enteric coated, all of those can help. Tremor, one of the most common neurologic symptoms with this drug. It's one to keep in mind if somebody comes to you with an essential tremor. Look at for drug-induced effects. This is a common one. Okay, so 25% of people who take valproic acid, and I've read up to 45% of some patients in some reports of tremor, occurs early in therapy, so it's going to show up soon after you start it. It looks like an essential tremor, so it's mostly upper body, head, face, arms, shoulders, neck. Most of the time, the neurologic side effects of these drugs will respond if you can reduce the dose. So backing the dose down a little bit, the tremor may go away. It will not go away fully, or it may not go away fully unless you stop the drug. It is reversible. It is a reversible cause. If you cannot get it fully reversed and the patient is complaining or it's bothering them, you can use propranolol. So it's easy. Easy to remember the treatment. Questions about that? Thrombocytopenia. So platelets and valproic acid. Keep that in mind. 12 to 18%, you'll see different variances in different reports. Some report higher. Most of the time it's mild, so usually the platelets are in about the 100 or less than 150,000. What's normal platelet level? 200 to 400,000. 200,000 to 400,000. Okay. So usually a mild reduction Patients may remain asymptomatic. Some people will have severe. They may get as low as 50,000. It may be that you only find it on lab, or they come in with complaints of abnormal bleeding, or they develop petechiae. Okay? You remember what petechiae are? Okay. So they may complain of a petechial rash or bleeding. Okay. Lowering the dose may help. Usually more common in older folks, females, those on higher doses, like a gram or more a day. If it's not causing him trouble, you don't have to do anything. But if it is, you may be able, if you can back down the dose, that may be the best. Can also cause a subclinical hypothyroidism, usually found on lab. It usually doesn't, meaning it doesn't produce symptoms usually. So TSH will be slightly elevated, T4 may be in normal range or slightly depressed. Weight gain, significant. Usually occurs early in therapy. Women at higher risk, it can occur in 50% or more of patients. It's thought to be due to elevated insulin levels, so they lay down fat more easily. Again, dose reduction may help. Hair loss. Can you imagine hearing all this as a patient going, yeah, this is better than having a seizure? Okay, hair loss, common, it's dose related. The higher the dose, the more likely. So 10 to 12% common with usual moderate doses, close to 30% in people who are on the higher doses. Often affects women more than men. It may be just that the women complain more or notice it more. It is usually a progressive loss. It can be significant. Usually it's going to be patchy alopecia, so it's just going to be parts of their hair. And often it will grow back. It puts the hair follicle in kind of a resting phase. Now what makes it come out of that, I don't know. But most people will regain. Losing all their hair is really rare. So if you can reduce the dose, since it's dose related, that is one way to try. Some other things that are out that I found on the internet is biotin. So they recommend biotin supplements. It's not going to hurt them. The other is to avoid taking valproic acid with meals. They feel like it chelates trace minerals that are vital to hair health. Others recommend using zinc and selenium supplements. It isn't going to hurt them, it might help. And then just hair care. So soft brushes, mild shampoos, don't dye your hair, don't damage it, make it more likely to fall out. You could look at minoxidil, the topical minoxidil, but there really isn't any evaluation of it. There are recommendations out there, but there's nothing that's assessed it. So that one I'd be careful with because there's no data behind it. It is expensive and it has lots of side effects associated with it. But it might be something you consider if everything else does not work. And usually the hair will regrow. Polycystic ovarian syndrome. Have you all talked about that? Okay, we will in endo. So this is a syndrome that is usually associated with very high circulating androgen. It usually is associated, most women are diagnosed because they can't get pregnant. So it interferes with a lot of endocrine inner workings that lead to reproduction. It is the androgens associated with hair growth. So this is obviously affecting women. Increased risk of diabetes, increased risk of cardiovascular disease. So it is not a benign nothing. So increased incidence or cause of that. Hyperammonemia, so it can increase ammonia levels in the blood. Usually mild, most patients won't notice it. If it gets high enough though, it will cause symptoms. Seizure risk increases, lethargy, change in mental status would be a common one. Usually when we see high ammonia levels, we think liver disease. This is not liver disease. It's the interference of the drugs, of the ammonia, getting rid of ammonia in the blood by the drug. Usually not a problem. Or it's mild enough most patients tolerate, or decreasing the dose may help. So idiosyncratic too, to keep in mind, one, the most important one is the liver toxicity, because it is the most serious and the most fatal. Most likely to occur in children. So you'll see children under the age of 2 who are also on other anticonvulsants at most risk. Children who have other problems like inborn errors of metabolism, difficult to control seizures, these are the highest risk. They don't really recommend routine liver monitoring of people, but certainly people who present, or children who present early on in therapy and have those risk factors and have symptoms that could be indicative of liver failure need to be then monitored, of course. Pancreatitis, very rare, usually early on, younger patients on lots of medicines. And when I talk about multiple medications, I usually talk about other anticonvulsants. So the advantage is that it's very effective as a seizure medicine. It has lots of dosage forms, so it can be adapted to a lot of different patient needs. The problem are the side effects. It's a potent enzyme inhibitor, and there's lots of drug interactions. Comments on valproic acid? Anything I said that contradicted what you've already heard? Okay. Next one is topiramate or Topamax, another very effective drug, multiple mechanisms for its action. The good thing about, or the advantage to topiramate is that it's renally excreted. Doesn't have to undergo any change. So as long as your kidneys are working, you can get rid of this drug. It requires a slow titration. It has linear kinetics, which is a real plus. What does that mean? Predictable changes with increase of dose. So this is concentration, and this is increasing dose. So linear looks like that. If I change the dose from 100 to 200, I get the same effect if I go from 400 to 500. Okay? That's linear. That's good. Very predictable. We like that. The big thing with it are CNS effects. We talked about this with, where did we, I haven't done headaches yet. We've talked about this before. The big thing is anorexia. It is very common. 10% plus of patients will experience it. I've seen it mostly in women, but that's the people I've seen the most, or instead of it used in men. Early on, caloric intake, but it sustains. So they found that in people early on, because they just aren't hungry, they'll eat less, so weight goes down. But even at 1 year, they'll find that the caloric intake actually comes back to baseline, weight loss is sustained. So it does something in our ability to store energy. The higher the baseline BMI, usually the greater the weight loss. But even people who are skinny will still get some weight loss. But people who weigh more have greater loss. The other is the paresthesias we talked about. And I tried to find more information on it, but they're mostly case reports. So a lot of it's tingling. It's people complaining about, I can't pick my keys up, I can't sew, I'm having trouble picking change up off the counter. not painful, but just a loss of function due to the loss of sensation. Okay. Advantage, multiple mechanisms, very effective drug. Renal elimination, linear kinetics, very few drug interactions. Okay. So if you had somebody who had multiple interactions with drugs that you could not modify, or they're having side effects because of that, then this might be a drug to consider. The big thing is cognitive function and the other adverse effects, which can be significant. So those cognitive defects, remember, were like word finding, common, inability to concentrate, or decreased ability to concentrate. Okay, Keppra, levetiracetam. Okay. So this drug, it is very broad spectrum, often used as an adjunct, an add-on to other agents. Very effective. It also has lots of products, so it has a regular release, extended release, oral solution, IV. A lot of these are coming out with IV. Even the older products are coming out, so that if you have somebody who has temporary loss or ability to take oral agents, you can replace them. Usually these are for short term. If maybe they're admitted to the hospital and they're NPO, you can use the IV solution. So the good thing, renal elimination, yay. Metabolism is independent of that P450 system, yay. Drug interactions are few. It doesn't induce the liver enzymes, yay. Okay. Dose, again, start low, titrate, this says about every 2 weeks. Maximum dose is 4,000 milligrams a day. So it has a very wide range. That is good. I always like to see that because it tells me there's lots of ability to fine-tune the dose for the patient. CNS side effects most common: agitation, irritability, somnolence, lethargy. This will drive you nuts because you will find a lot of these drugs are CNS depressants, but they're also CNS activating. Depends on which part of the brain gets affected. Linear kinetics, yay. Well-tolerated sedation is the biggest problem with this drug. You will have to modify the dose in renal insufficiency. So a pretty easy drug to use. Another one that has come on the market that's very similar to it is Broviac. It's very similar to Keppra. There's not even anything big that I could tell you difference. Different drug. Different drug, looks the same. Gabapentin, you've heard of before. First came out as an anticonvulsant. We don't use it that much as an anticonvulsant. It's really good with pain control and for other problems, but it is one that can be used for refractory seizures. The American Academy of Neurology states that it could be used as monotherapy for a new focal epilepsy. I don't believe it has an FDA indication for that, but that's their recommendations in their guidelines. The big thing I want you to remember about gabapentin is renal elimination. Because we're going to see this drug a lot, all the time, often in older people. I can tell you the one drug I can almost always look up on an elderly person and find its dosed inappropriately because providers don't pay attention to the renal function with this drug. So keep in mind renal function. It's also very sedating. So a lot of times people like to take it at bedtime. If they're having trouble sleeping, if they've got neuropathies, this is a great one to give at bedtime. It's often recommended 3 times a day. So that one's a hard one for some people to do. BID, usually most people can get by. Sometimes you need 3 times a day just for symptom control. This one is like all the others, titrate it slowly because of mostly the ability to tolerate the sedation. Use it with caution in other sedating drugs. So if they're on benzodiazepines or opiates. So when we get to pain control, they may also be on other centrally acting drugs that also sedate them. So keep that one in mind. Pregabalin or Lyrica, very similar to gabapentin. There's not a whole lot of difference. The one thing these drugs can do is they can make patients ataxic. They neurologically are, they may want to walk straight and there's no way to do it. Or sometimes they get weird choreiform movements. They may complain of that. But again, they are usually fairly well tolerated except for the sedation. I have no idea what time it is. Okay, since we're at a break point, let's stop here and we'll pick up with glutamate receptor antagonist after the break. So come back at 11.